Hello everyone. So today we from SGD B9 are going to talk about hyperaldosteronism as the topic for our student project. And here are the members of our study group. My name is Sarah with NIM number 073. Now I'm going to talk about the background. So hyperaldosteronism is an endocrine disorder that involves one or both of your adrenal glands creating too much of a hormone called aldosterone. This condition may be dominant or secondary, with each appearing in the same way but being distinguished by a series of lab values and diagnostic tests. It is usually asymptomatic, but around 10% of hypertensive patients have primary hyperaldosteronism, with cardiovascular disease as the most frequent morbidity associated with this condition. This student project aims to help the medical students to learn and understand hyperaldosteronism so they are able to manage and treat the patients with this condition.
So formulation of problems for these papers are: what is the definition of hyperaldosteronism? What is the etiology of hyperaldosteronism? How is the epidemiology of hyperaldosteronism? How is the pathophysiology of hyperaldosteronism? What are the clinical features of hyperaldosteronism? How to diagnose hyperaldosteronism? What are the differential diagnoses of hyperaldosteronism? What are the complications and how is the prognosis of hyperaldosteronism, and what are the management of hyperaldosteronism? And the purposes for this paper is to answer all of the questions from the formulation of problems. And the significance for this paper are as the basic information about hyperaldosteronism for the future research and increased knowledge about hyperaldosteronism.
My name is Saras, number 25. So the definition of hyperaldosteronism. Hyperaldosteronism is characterized by excess production of aldosterone from the adrenal gland. After hyperaldosteronism is found with symptoms of essential and refractory hypertension and after undiagnosed. Aldosterone plays a role in regulating extracellular volume and electrolyte homeostasis through its effect on the distal convoluted tubule of the kidney. Aldosterone activates the mineralocorticoid receptor in the distal nephron and thereby increasing the expression of epithelial sodium channels, and through this channel sodium is reabsorbed, giving rise to the potential electronegative luminal and triggers the release of the cations from the cell, namely potassium and hydrogen ions. And so that in this condition of hyperaldosteronism, there is an increase in sodium reabsorption and a decreased potassium and hydrogen ions. This could be a primary or secondary aldosteronism. The primary aldosteronism is caused by excess production of the hormone aldosterone by the adrenal glands and mainly is in the glomerular zone. And for the secondary hyperaldosteronism occurs due to the excessive activation of the renin-angiotensin-aldosterone system, and this can be caused by a renin-producing tumor, renal artery stenosis, or edematous disorder like left ventricular heart failure, pregnancy, or cirrhosis with acid-test tumor.
Hello, my name is Ana Agung Ayurata Indira Putri, NIM 174. The cause of the excess production of aldosterone differentiate primary from secondary hyperaldosteronism. Primary hyperaldosteronism is due to the excess production of adrenal gland, more specifically the zona glomerulosa. It can present more commonly as a primary tumor in the gland, known as Horn syndrome or bilateral adrenal hyperplasia. Rare form from primary hyperaldosteronism is unilateral adrenal hyperplasia. Ectopic aldosterone secreting tumors, aldosterone producing adrenocortical carcinoma, familial hyperaldosteronism type 1. While the secondary hyperaldosteronism occurs due to excessive action of the renin-angiotensin-aldosterone system or RAAS. This activation can be to the renin-producing tumor, renal artery stenosis, or edematous disorder like left ventricular heart failure, pregnancy, or cirrhosis with acid test.
My name is Angel Fonchafas with the last registration number 091. Now I will elaborate with the epidemiology of hyperaldosteronism. Autonomous production of aldosterone due to an adrenal adenoma was first reported in 1954 by Kahn. The clinical symptoms resulting from the excessive production of aldosterone in hypertension, hypokalemia, and metabolic alkalosis. This syndrome is then named after the person who reported this case, Kahn's disease or primary hyperaldosteronism. The prevalence of primary hyperaldosteronism has varied from 4.6% to 16.6%. Disparity in these percentages is affected by the use of different laboratory screening techniques, different definitions of a positive screening study, indicative of primary hyperaldosteronism, study design, and also varying population ethnicity and sampling source. Recent reports describe hypokalemic primary hyperaldosteronism in only the minority of primary hyperaldosteronism cases, or under 40%, and describe an intermediate phenotype of normotensive primary hyperaldosteronism with milder manifestations than the classic hyperaldosteronism in hypertensive patients. Up to 63% of patients with primary hyperaldosteronism may be normocalemic. A recent study suggested that primary hyperaldosteronism was diagnosed in 12% of normotensive and normocalemic people with adrenal incident thalamus. Primary hyperaldosteronism can be seen in about 10% of hypertensive patients. Secondary hyperaldosteronism is diagnosed less often than primary hyperaldosteronism, and both primary and secondary hyperaldosteronism present more frequently in women.
My name is Kamaldini Sani, number 98, and I will tell you about the pathophysiology of primary hyperaldosteronism. Primary hyperaldosteronism is a condition of increased secretion of aldosterone renin independent. This is commonly caused by aldosterone-producing adenoma and idiopathic hyperaldosteronism or bilateral hyperplasia. In rare cases, it is also caused by unilateral hyperplasia, adrenocortical carcinomas, familial hyperaldosteronism type 1, 2, or 3, and ectopic aldosterone-producing adenoma or carcinoma.
One doctor, my name is Joseph Messi with the name of 2050. So today I'll be describing the pathophysiology of secondary hyperaldosteronism. So secondary hyperaldosteronism is caused by some things that are outside the adrenal glands and is related to reduced blood flow to the kidneys. The decrease of renal perfusion will cause the decreased blood flow to result in PRA elevation, and this elevation will increase the production of aldosterone. This may also happen when there is renin and angiotensin II stimulation of the zona glomerulosa with resultant hyperexcretion of aldosterone. Heart failure, nephrotic syndrome, cirrhosis of the liver, and other hyperproteinemia conditions in which there is chronic depletion of plasma volume can also elevate the plasma and aldosterone.
Okay, my name is Pierre. Last 3 digits of student number 077. So patients suffering from hyperaldosteronism can have several signs and symptoms, but sometimes patients don't show there's any signs of symptoms. In symptomatic cases, the patient usually have mild to severe hypertension, which can be helped by pharmacotherapy. Even with the use of more than 5 types of anti-hypertensions, a patient will still have the hypertension, which is called resistant hypertension. Patients might also have nausea, dizziness, headache, dyspnea, and some problems with visual function or visual impairment. And those mentioned signs and symptoms are the complication of the hypertension.
Okay, first my name is Gabriela with the number 169, and I want to tell about the diagnosis of the hyperaldosteronism. The diagnosis of the primary hyperaldosteronism is carried out by measuring the level of the aldosterone and renin in the blood with sample taken in the morning for the better result. Patients with primary hyperaldosteronism will find high aldosterone levels and low or unacceptable renin. Potassium level may be low or normal. Another test can be done as follows is PAC ratio. This blood test is a screening test, meaning it's performed if hyperaldosteronism is suspect but hasn't been diagnosed. Most studies support an elevated PAC to PRA ratio. It indicates primary hyperaldosteronism, but additional testing may be needed to confirm the diagnosis. And the second is catheptal emphasis test. It is a blood test that measures body response to the catheter, a drug used to treat hypertension. And the third is 24-hour urine secretion aldosterone test. This can be done by administering oral sodium for 3 days. Then the urine aldosterone is measured. A value more than 12 microgram per day indicates a diagnosis of the hyperaldosteronism. And the last is saline suppression test. The patient receives a saline solution through the infusion, and then a blood test was carried out to measure the patient's aldosterone and renin level. If aldosterone level in the blood remain high and the renin is low after administration of this salt, this indicates primary hyperaldosteronism.
Hello, my name is Ferdinand with digit number 108. About the differential diagnosis: first, essential hypertension; second, Liddle syndrome; third, syndrome of apparent mineralocorticoid excess; fourth, congenital adrenal hyperplasia; fifth, primary glucocorticoid resistance; and sixth, ectopic adrenocorticotropic hormone or ACTH syndrome. These all diseases or syndrome have shown the similar symptoms.
My name is Universitas, NIM 125. I'll explain about the complications and prognosis of hyperaldosteronism. The morbidity and mortality of patients with hyperaldosteronism are associated with chronic hypertension, which may result in increase in cardiovascular disease. Patients who have received surgical adrenalectomy have a better prognosis than patients who only received medical therapy. 10-year survival rates in hyperaldosteronism treated patients are 90 until 95%.
Hello doctor, my name is Dava Satrianda, student number 146. For the treatment itself, two of them being adrenal vein catheterization and unilateral adrenalectomy. For adrenal vein catheterization itself, it is a complex and invasive procedure where it is used to determine whether a patient is suffering from hyperaldosteronism or not. And it is used to calculate the amount of aldosterone secreted by the body. For unilateral adrenalectomy, the procedure is invasive and a significant percentage where the blood pressure controls improve post-surgery, and the others remain. Factors associated with persistence of hypertension include family history, which is found in approximately 60 patients suffering from hyperaldosteronism. Another thing that may happen is the deterioration of renal function relating to resolution of the hyperfiltration after surgery.
Okay, so my name is Ana Agung Rahpradana Antadiva. I'm going to tell you about the summary. Hyperaldosteronism is caused by the increased release of aldosterone by the adrenal gland. This could be primary or secondary aldosteronism. Primary hyperaldosteronism is caused by excess production of the hormone aldosterone by the adrenal glands, mainly in the zona glomerulosa. Secondary hyperaldosteronism occurs due to excess activation of the renin-angiotensin-aldosterone system, or AAS. Patients suffering from hyperaldosteronism can have several signs and symptoms, but some patients don't show any signs or symptoms. The diagnosis of primary hyperaldosteronism is carried out by measuring the levels of aldosterone and renin in the blood with samples taken in the morning for better results. The morbidity and mortality of patients with hyperaldosteronism are associated with chronic hypertension. Few ways have been shown to help treat primary hyperaldosteronism, or HPA, such as adrenaline vein catheterization and unilateral adrenalectomy. Thank you.